We started this. My name is Maria Paola Martelli. There is a change in the among us moderator. Yes, here with Dr. Yüksel from Turkey. It's my pleasure to moderate this section. Leukaemogenic drugs and treatment of therapy-related myeloid neoplasm, and I introduced the first talk by Professor Danesi from the University of Pisa, leukaemogenic effects of topoisomerase inhibitors, alkylating agents, and new drugs. Please.
Okay, thank you. I start with the sharing of the screen. So I hope that you can see the screen and also hear my voice in a clear way.
Yes, we do.
Okay, great. So first of all, thank you very much for inviting me at this conference. I very much apologize for not being with you due to concomitant institutional commitments. Sorry for that. As you can see here, I mean, the title of my presentation is the Leukaemogenic Effects of Topoisomerase Inhibitors and Alkylating Agents. I am a pharmacologist. I work in the University of Pisa, and I am chairman of the unit of pharmacology and pharmacogenetics in my university. And also we have a clinical service to support clinical decision-making by clinicians in that respect. So I like to start with the typical biological and clinical characteristics of acute myeloid leukemia associated with the administration of alkylating agents and topoisomerase inhibitors. As you can see here, the TAML is a typical adverse event classified as a delayed adverse event. In the general classification of adverse events, we classify these kind of sequela of treatments as a D category. Why? Because there is a latency period, which is shorter in topoisomerase 2 inhibitors, as you can see here in the central column, and is longer with alkylating agents. So we start with 2 years or less with topoisomerase inhibitors, and we have 2 to 8 years with alkylating agents. There are chromosomal abnormalities associated with this disease. Recurrent translocations are usually involving MLL. In the topoisomerase 2 associated AML, other genetic abnormalities are involved in the generation of TML in the case of alkylating agents, like deletions involving chromosome 5 and 7. There is a complex karyotype in alkylating agent associated AML, which is rare, on the contrary, in the case of topoisomerase 2 inhibitors. It is this kind of complex disease is preceded by myelodysplastic syndrome in the case of alkylating agents, which is rare, on the contrary, in topoisomerase 2 inhibitors. And the younger the age category in the topoisomerase 2 induced TAML, while it is older in the case of alkylating agents. So this is just to present you the complexity of this adverse reaction. This reaction is based on the DNA damage response, which is typical in the case of single-strand breaks and double-strand breaks. In the case of double-strand breaks and also in the single-strand breaks, we have a machinery inside the cell which is involved in the so-called DNA damage response, which is based on the complex involvement of sensors, as you can see in the central part of the slide, mediators, transducers, effectors, and the typical consequences, which are DNA repair, which is the best option. I mean, the repair of the DNA without residual damage. On the contrary, we can have a cell cycle arrest and apoptosis, so the death of the cell, or simply senescence. Cell cycle arrest is typical in many cases because it is associated with the DNA repair mechanisms, which are based on a very complex number of different enzymes. You can see on the right side of the slide, in which DNA repair mechanism, they play a very complex role. There is a multifactorial combination of different effectors. Of course, I will not examine in detail these, because what is important for me is to classify the different drugs involved in the phenomenon of therapy-induced myeloid neoplasia. You can see here the major monofunctional alkylating agents associated with these adverse reactions. On the left side of the slide, you can see the dacarbazine is a monofunctional alkylating agent together with procarbazine, temozolomide. The typical DNA adduct is the methylation of guanine, typical of temozolomide mechanism of action, but also we have methylation of adenine in position 3, and again, guanine in position 7 and also in position 6. We also have double-strand breaks. There are a number of enzymes involved in DNA repair. The methylguanine methyltransferase is the typical enzyme involved in the demethylation of guanine as a repair mechanisms. And also the mismatch repair enzyme machinery is involved in the repair of DNA adducts induced by these methylating agents. Also, there are homologous recombination pathway involved in the repair of the double-strand breaks, and the base excision repair in the repair of the methylation at the adenine and guanine levels. The DNA damage induced by methylating agents is described in more detail in this slide, where you can see what we have already mentioned in the previous slide. On the left side of the slide, you can see the general mechanism of repair by the base excision repair, consisting of a repair of the methylation of the adenine or guanine. On the right side, you can see the repair by the methylguanine methyltransferase, the MGMT enzyme, which plays a very important role in the response to temozolomide, for instance, in central nervous system tumors. And the target of this repair is the, you can see in the red box, the methylation of guanine in position 6. Another important system of DNA repair is the mismatch repair, the MMR. You can see here that the mismatch repair mechanism is involved in the repair of the double-strand breaks. If the MMR is unable to repair, there is a toxic death of the cell. And the development of secondary leukemias, you can see in the right side of the slide, due to myelotoxic treatment, is typically due to a loss or inefficiency of the mismatch repair mechanism, which brings to methylation tolerance, mutator phenotype, and at the end, the therapy-induced myeloid leukemia. Let's have a look to the bifunctional alkylating agents associated with the development and occurrence of myeloid neoplasms. You can see the drugs here on the left side of the slide: BCNU, CCNU, and ACNU. These are the very old typical alkylating, bifunctional alkylating agents. They typically produce interstrand cross-linkings and also cross-linkings between DNA and proteins associated with DNA. These mechanisms of toxicity are typically repaired by, again, the methylguanine methyltransferase, the MGMT, the FANK pathway, based on the activity of enzymes belonging to the homologous recombination or nucleotide excision repair systems, and the DNA protein cross-links, which are less important, are repaired by the base excision repair system and non-homologous enjoining mechanism of repair, the NHEJ. Cyclophosphamide is a very well-known drug. It is associated with the generation of interstrand cross-linkings. You can see in the central column of the slide under the DNA adduct legend. You can see also monoadducts, generation of acrolein, which is a toxic metabolite of cyclophosphamide, and also in this case, the DNA protein cross-linking. Again, the mechanism of repair is based mainly on the FANK pathway, homologous recombination, and nucleotide excision repair. Less important is the MGMT enzyme. Then chlorambucil, also in this case, you have a drug which generates monoadducts, interstrand and interstrand cross-linkings, so involving both filaments of the DNA and also within the same filament of DNA. And also in this case, the nucleotide excision repair and homologous recombination are the most important enzyme systems involved in DNA repair. Other drugs are melphalan, busulfan, and platinum compounds. The kind of DNA adduct they produce is more or less the same as seen before. And also the DNA repair systems involved in the repair of the DNA are the same, with different involvement of nucleotide excision repair or base excision repair, depending on the specificity of the drug involved in this reaction, in this damage. It should be considered that deficiency or malfunction of the DNA repair systems allows the accumulation of DNA lesions and, as a consequence, mutagenesis and late development of myeloid neoplasms. The activation of cyclophosphamide and many other alkylating agents is very complex. You can see here the example of cyclophosphamide, which is metabolized at the liver level by the cytochrome P450 enzyme, which is a family, a very large family of enzymes, which transforms cyclophosphamide into hydroxycyclophosphamide. And then after different intermediates and other additional enzymatic steps, you can see here the generation of phosphoramide mustard, which is the alkylating agent, active metabolite, and acrolein, which is the toxic metabolite. The mechanism of action of alkylating agent has already been described, but just to show in a graphical way in which way they contribute to the damage to the DNA, you can see here that alkylating agents may act not specifically producing cross bridges and making the DNA impossible to replicate. So the general effect will be prevention of replication or transcription. But which is most important for the mutagenic effect, you can see on the right side of the slide, the appearance of mutations. In this case, the agents act specifically by inducing mutagenesis at different levels in the DNA. These mutations can bring mispairing or DNA fragmentation, but mispairing is very important because in the subsequent cycles of replication, the mutation will be incorporated and become stable. If the DNA repair enzymes are efficient, of course, this consequence is avoided. But if the DNA repair enzymes are misfunctioning, the accumulation of mutations is a very common event. Let's have a look to the inhibitors of topoisomerases associated with the risk of occurrence of therapy-induced myeloid neoplasms. You can see here examples of topoisomerase 2 inhibitors like etoposide, doxorubicin, epirubicin. The kind of DNA lesion they produce are double-strand breaks, the DSBS, you can see under the column with the label DNA adduct. So with the toposide, you have double-strand breaks repaired by the homologous recombination system. With doxorubicin, you have, again, double-strand breaks, but also oxidative damage, which is typical to in the general effect of doxorubicin. The repair mechanism is quite complex. It involves homologous recombination, nucleotide excision repair, base excision repair, and non-homologous end joining. The same effect is characterized by doxorubicin because it's a derivative of epirubicin, which is a derivative of doxorubicin. Another topoisomerase 2 inhibitor is mitoxantrone. Again, in this case, you have oxidative damage and double-strand breaks. DNA repair systems are the same. And the last example is camptothecin, which is a topoisomerase 1 inhibitor, which induces single-strand breaks and also double-strand breaks. Repair of the DNA is again mediated by homologous recombination or non-homologous end joining. Let's have a look to the topoisomerase 2 mechanisms. This enzyme cleaves both strands of a duplex DNA segment. Then the second duplex passes through the enzyme-dependent coupled break. And then, as the last part of the reaction, the first duplex is relegated and the products of the reaction are released. So with a topoisomerase 2 inhibitor, you can interfere with this complex enzymatic reaction. It is important to consider that topoisomerase poisons inhibit the reverse reaction, the relegation, which results in stabilization of the 5' phosphoteresyl DNA complex, the so-called cleavage complex, which contains a top 2 linked strand break. So it is important to consider that topoisomerase poisons inhibit only one part of the reaction, because topoisomerase is able to cleave and religate DNA. So consider that only the religation is inhibited by the topoisomerase poison. And this produces a number of fragmentations along the DNA. Also, etoposide undergoes a complex metabolic pathway, and the transformation. You can see here that etoposide is metabolized by C3A4 in the liver to a very reactive intermediate, which is the etoposide cathechol, which is further metabolized by oxidase to the very unstable etoposide quinone, which is detoxified by, you can see in the bottom of the slide, by the glutathione S transferase. If the detoxification does not occur, there will be an accumulation of etoposide quinone and DNA damage, which is important in the generation of treatment-induced myeloid neoplasms. This is just a figure depicting the effect of topoisomerase 2 in physiological conditions. You can see on the left side of the slide, you can see the association of topoisomerase 2 to DNA, the binding, the generation of the non-cleavage complex, cleaving of the DNA, religation, resealing, and there is a continuous circle characterized by the initial part of the DNA replication. On the contrary, if you have a toposide which blocks this reaction, you have the trapping of the cleavage complex, you have the double strand breaks, you have the irreversible damage to the DNA. So just the last slide to comment this aspect, the downstream events of topoisomerase 2 poisons. They, as I said before, they inhibit the relegation step of the TOP2 reaction cycle, leading to accumulation of covalent TOP2 DNA cleavage complexes. These lesions are mainly cytotoxic and lead to the activation of the DNA damage response and potentially apoptosis. But if they are not repaired, such translocations are observed in therapy-related leukemia and are presumed to occur as a result of misrepairing of the DNA damage due to joining of the two heterologous ends. You can see on the bottom part of the slide the different options: apoptosis, DNA damage response, repair, or permanent damage. This is just a picture summarizing all the effects induced by the etoposide quinone, the very important and highly reactive metabolite. You can see the different options. You can have DNA translocation, MLL, and leukemia. You can have cell death. You can have apoptosis or mitotic failure. You have a number of different options, and among them, leukemia is a possibility, unfortunately. There are also factors involved in the development of therapy-related acute myeloid leukemia. In addition to the drug, you can have the combination of topoisomerase 2 inhibitor with antimetabolites in multiple combinations. You may have a low TPMT and low GST as a detoxificating enzymes. They are involved in the development and in the risk of leukemia after treatment. So consider the importance of additional factors, not only the primary factor, which is the drug, but also the lack or misfunction of repair mechanisms. There are antimetabolites also associated with the risk of occurrence of myeloid leukemia, fluorouracil, fludarabine, azathioprine, but they are less important in terms of epidemiology of this important and severe complication of treatment. I'd like to conclude, and thank you again for listening to my presentation, that many complex factors influence the risk of second malignancies after cancer treatment. Of course, chemotherapeutic protocol, doses, extent of damage, repair, and the age and lifestyle choices of the patient. Of course, DNA repair is a significant determinant of risk for therapy-related cancers. So malfunction, dysfunction, or inefficient DNA repair is the base for the development of this adverse event. And on the other end, since only a small percentage of patients exposed to cytotoxic therapy develop therapy-induced myeloid neoplasms, it has been suggested that genetic predisposition to second cancers may be associated with polymorphisms in genes involved in detoxification. So the metabolism is so important in the DNA damage response and repair. And again, thank you very much for inviting me at this conference.
Thank you, Professor Danesi, for this comprehensive overview and detailed overview on drugs that we commonly use to treat different kind of tumors, including leukemia, and that illustrates how the interdisciplinary approach to understand these severe diseases is very important. Is there are there any questions from the audience? You have?
Thank you very much for your brief summary. We have been discussing TMNS for almost a day, and this brief review has really helped us to understand it very well. My question is related to telomerase activity and telomeres during this exposure to the alkylating or those drugs. Do you have any data that they also change during this process?
Yes, there are data mainly on and with alkylating agents. They are able to affect the functionality of telomerases in a quite clear way, we should say, even though the alkylating agents are quite different in terms of activity on telomerase, being the bifunctional alkylating agents more active on or interfering with the telomerase activity with respect to monofunctional alkylating agents. We have few data, at least experimental preclinical, with the topoisomerase 2 inhibitors.
Can we use them to predict the risk for TMN?
Yes, although much attention has been devoted to the risk of developing myeloid neoplasms based on the functionality of the repair enzymes. Those are the main targets, the main interests of current research. Telomerase is very important. I agree with you absolutely, but probably has received less attention with respect to the role attributed to the repair enzymes in the development of a risk model for therapy-induced myeloid neoplasms.
Thank you.
Welcome.
There is a question from online, but yes, you have the
Check.
in the chat.
Is it in the chat?
Yeah.
Yeah. Well,
I can.
thanks for the talk. A recently published article in Blood implicated a risk of TMN from the usage of the very commonly used drug lenalidomide. Are the mechanisms known how LEN causes TMN?
I'm sorry, I missed the name of the drug.
Lenalidomide.
Lenalidomide. Okay, great. Well, yes. This is drugs belonging to the thalidomide and derivatives are very complex in their mechanism of action. It is not associated with the direct damage of the DNA, of course, because those drugs are not interfering directly on the DNA structure. but on the effect of immune effects. We know that lenalidomide, pomalidomide also are able to modify the population of immune cells infiltrating the microenvironment. And probably the immune effect of these drugs is the reason of the rare occurrence of neoplasms in the treated population, which is indeed a risk anyway, being due to genetic background to develop such a adverse event.
I have another question regarding the ATM/ATR inhibitors. How do you see the employment in therapy of these inhibitors to increase the sensitivity of chemotherapies? But I think that can be a risk for secondary tumors. How do you see the employment of these drugs, the development of these drugs?
Yeah, these drugs are very attractive. Also, I should say that also PARP inhibitors are, I mean, together with the these new drugs of chemotherapy. I should not say chemotherapeutic drugs targeting specific pathways. The ATM kinase inhibitors are probably involved in the potentiation of the DNA damage induced by classical DNA damaging agents. It is interesting also to see how PARP inhibitors also participate with the inhibition of PARP ylation in the increase in the DNA damage and the risk of therapy-induced myeloid neoplasms. Well, I should say that ATM and PARP inhibitors among the new drugs are interesting drugs, drugs to observe with great attention in order to understand the full potential of these drugs to contribute to the treatment-induced myeloid neoplasms.
Thank you.
Yes, please.
Professor Leone?
Excuse me, but do you think that all drugs can intervene directly, or there are some drug or some therapy that could influence the immune system and then favor the insurgence of leukemia or the other tumor? For example, in this meeting has been reported some secondary leukemia after TCAR therapy.
Well, yes, this is a very good point. It is a very complex story to decipher because immune system on one side and alkylating agents or agents directly acting on DNA are the two elements of the story. I would like to add also the lifestyles to, I mean, the overall consideration concerning the risk of developing such kind of adverse reaction. For instance, we know that anti-tumor necrosis factor, the anti-TNF-alpha are associated, which are used in a totally different clinical setting, like the immune-mediated inflammatory diseases, are associated with the low risk of secondary cancer. So again, the modulation of the immunity and the immune system by drugs like lenalidomide or other drugs in other conditions like the anti-TNF alpha are important for the development of the therapy-induced secondary tumors. So complex scenario, of course, in which the primary acting drugs like damaging drugs to the DNA and additional treatments modulating immunity are really important for the development of the therapy-induced myeloid neoplasms, although it is different to say which is the relative weight of these lifestyles, drugs, drug modulators, directly acting on the DNA.
Thank you.